So my topic is recurrent implantation failure, definition, diagnosis, and management. So my agenda, I will be first going through the definition. Well, the 2017 glossary defines implantation as the attachment and subsequent penetration by a zone of free blastocysts into the endometrium, and this process starts 5 to 7 days after fertilization of the oocyte, usually resulting in the formation of gestational sac. And this process, implantation, is a continuum. And disruption might occur at any stage of this continuum. If it occurs at the early stages, then we will have no detectable beta-HCG production. If at later stages, biochemical pregnancy loss. Even if it more later stages, it will be resulting in pregnancy loss. And we should also recall that failure of embryo implantation is also very common after naturally occurring fertilization. This is the Nick Macdale study, and of all spontaneous conceptions, at least 60% are lost before they are clinically recognizable. And regarding IVF, implantation rates have gradually increased since Louis Brown, but still, I mean, 30%, 35% of the blastocysts, even at very good programs, fail to implant at the very good, IVF programs. And this failure and such failures are distressing, not only for the couple, but also the physician and the IVF center. And if recurrent, obviously it is devastating. The terminology recurrent implantation failure denotes a milestone during the transfer of multiple embryo transfers, all of which fail to result in implantation failure. And the recurrent nature of such failures suggests an underlying unknown etiology that might affect the subsequent transfers, necessitating additional diagnostic or therapeutic interventions to improve the success. As when one goes to the literature, and this is a systematic review published in 2014 by Polanski, look at, in around 119 included studies, there were 76 different definitions. Also, these definitions were impacted by the changes in IVF practice, from multiple embryo transfers to single embryo transfers, from the cleavage stage to blastocyst stage, untested to tested blastocysts. But with the different thresholds. And in line with all these, difficulties, there have been criticism for the definition and whether such an entity exists. To emphasize the overdiagnosis of RUF, Somigliani and his colleagues published a model. And within this model, this is a theoretical model, by the way. And within this model, the prevalence of RUF was assumed to be 10%, and the pregnancy rate of 30% in unaffected couples, where it is 0% in RUF cases. So these RUF cases, 10% cases, would never ever attain a pregnancy. And then they depicted the clinical pregnancy rate for the first, second, third, and so on transfers. And also they calculated the cumulative probability of pregnancy. So it was 79% after the 6th attempt. And they also calculated within this theoretical model, they calculated the false positive rate. In other words, women who would be labeled as RUF, although they did not get pregnant just due to statistical misfortune. And one can see that with different scenarios, with different clinical pregnancy rate per attempt, and remember, this clinical pregnancy rate per attempt was the same during the consecutive attempts. And in this model, since they started with a clinical pregnancy rate of 30%. So at the end of the third attempt, the false positive rate for making the diagnosis of RUF was 75%. And even at the sixth failed attempt, 1 out of 2 patients would be mislabeled as RIF, although they did not get pregnant just due to statistical misfortune. And more recently, a group from Australia, they introduced the terminology theoretical cumulative implantation rate. And they also produced an example. 28-year-old woman has 3 single embryo transfers, each with good quality embryo, and with each associated with 40% positive beta HCG rate. And the chance of not being pregnant after 3 attempts would be calculated by multiplying 0.6, 0.6, 0.6. And if you subtract this from 1, then you will be calculating the cumulative pregnancy rate. And if no pregnancy is attained following embryo transfer with an anticipated cumulative implantation rate above a threshold that is regarded high enough to rule out an implantation failure due to randomly occurring misfortune, then the patient can be diagnosed rift. And then they suggested an arbitrary threshold of 80%. And they also provided a table in which, with different scenarios, I mean, per embryo transfer, either 50%, 45%, the chance, and also they tabulated with the number of attempts. And one can see that for a scenario with 50% chance of pregnancy per attempt, the patient would be fulfilling the diagnosis of brief after 3 attempts, whereas with a scenario of only 10% chance of pregnancy per attempt, she would be fulfilling the diagnosis after 16 embryo transfers. And even for a 5% chance of pregnancy per attempt, she would be fulfilling the diagnosis after 32 embryo transfers. But this study was very valuable, and also the authors acknowledged the importance of the female age, plody status, the embryo quality, but they did not provide how to adjust, how to make the adjustments based on these prognostic factors. And Barış Ata from Turkey, a very good friend of mine, they also provided another model. And in this model, their assumption was that random aneuploidy is the sole factor for implantation failure. The female age is the sole factor for embryo aneuploidy, and the chance of implantation would be the same during consecutive trials. With these 3 assumptions, they took the euploidy rates from the available studies in the literature, and then with the assumption of implantation rate per single tested embryo as 45%, and using a formula, they depicted the number of, in the x-axis, they have the number of untested embryos, and y-axis, the number of, the cumulative probability of implantation. And they also provided the data for different clinical settings with implantation at 55 or 65%. And they took the threshold for RUF as 95%. And they once again emphasized the overdiagnosis of RUF. And in this model, woman under age, 35 years old, should have 7 untested failed embryos to make the diagnosis of RUF using this model. And these numbers obviously change drastically when the embryos are tested. By the way, the goal of this study was not to advocate pre-implantation genetic testing for aneuploidy, but just to stress that the number of, untested embryos should be adjusted based on the below this status. And with the tested embryos, say with an the implantation rate per embryo transfer of 55%, you would attain, 90%, and with transferring of 4 tested embryos, then you would be attaining 95% implantation rate. And more recently, the Este working group on RUF described the scenario as the transfer of embryos considered to be viable has failed to result in a positive pregnancy test. So they took the point, arbitrary point as a positive pregnancy test sufficiently often in a specific patient to warrant consideration of further investigations and or interventions. And they also recognized the various, the female, male-related, embryo-related factors and external factors that might affect the reproductive outcome. And they quoted that there are 2 factors essential to calculate the cumulative chance of successful pregnancy. First, estimating the chance of implantation. Either one might be using the data from observational studies or preferably the IVF's own data. And the second way might be using the existing models. And the second is one should be setting a threshold for the cumulative chance of successful pregnancy. And the group on an arbitrary basis also has taken 60% as the threshold. And they gave example. This is, you can estimate the chance of cumulative pregnancy from this, web-based available to everybody from the IVF predict calculator or on data. And also, they also acknowledge that even though, say, in a patient, the cumulative chance of probability with only single embryo transfer might exceed 60%, in order to make this diagnosis, there should be at least 2 embryo transfers. And then what they figured out is that at least 2 embryo transfers failing to result in pregnancy. And then what was you calculate the cumulative chance of implantation pregnancy over the course of embryo transfers. If it is less than 60%, you keep on doing IVF. And if it exceeds 60%, then you can be making the diagnosis of RUF. More recently, the Lugano RIF workshop also proposed another model. So in this model, the endpoint was sustained implantation. In other words, gestational sac visually at the ultrasonography. It might be at a better interest for the patients and physicians rather than a being positive pregnancy. And also, it might be using this parameter would also be avoiding the miscarriages. So assuming that the prevalence of recurrent implantation failure was 10%, on those patients, depicted in the green bars, assuming there's 10%, those patients would never ever get pregnant, irrespective of the number of IVF cycles. And if it is 70%, then with the first attempt, the live birth rate would be 63%. With the second attempt, and now since this 10% is there, regardless of the number of cycles, this time, this 10% would be enriched in the denominator. And thus, the live birth rate in the second embryo transfer would be 51%. It would be more enriched in the denominator, this 10%, and therefore the live birth rate is 31%. So this is just a theoretical assumption, theoretical model. So is it the case in the real world data? Well, this is the famous, the Purtea study from Richard Scott's group from New Jersey. And the first attempt is a 64.8% the live birth rate per single embryo transfer. The the first attempt is a little bit significantly higher compared to the second and third attempts, but the second and third attempts have similar live birth rates per embryo transfer, and resulting in 93% over the 3 haploid single embryo transfers. And with this data, they tabulated that, and by the way, these cases were obviously frozen embryo transfer cycles using HRT with IM progesterone with intact uterus, with no BMI restriction. And with this model, their assumption was that the real RIF cases might be somewhere between 1 to 5%. And more recently, with a multi-center study presented as a poster at the recent ASRM meeting, looking at the fourth, for those patients who failed the first, second, and third attempts, looking at the fourth haploid and the fifth haploid embryo transfers, and the live birth rates for the fourth and the fifth ones are equivalent. So if this is the case for these RIF cases to be enriched in the denominator, they should be decreasing, which is not the case. And these data were about the fourth transfer was 105 cases and the fifth was 45 cases. Obviously, these cases, even at the very, busy IVF clinics, are very rare because the majority conceived during the first, second, or to the third attempt. And as a subgroup analysis, they looked at just looking at the EVRMA New Jersey data, the Purtea study, plus the fifth attempt and the fourth attempt and the fifth attempt. I'm sorry, there has been a secretary mistake. And then you look at the cumulative live birth rate. It is now 98.1%. So only 1.9% failed to implant. So unexplained RIF should be even less, less than 2%. So once again, these are HRT cycle, IM progesterone with intact uterus at vaginal ultrasonography. And therefore, the group made the recommendation that it would seem reasonable not to assign this diagnosis to a patient until she has fed off at least 3 haploid embryo transfers or the equivalent number of unsequenced embryos adjusted to her age. So implantation or its failure is to a very great extent dictated by the embryo as long as the uterus is intact. And this obviously to a great extent dictated by the egg. But obviously we should also not deny the seminal plasma or sperm factor, which we should be exploring more. This personalized definition of RIF, there are also other issues that should be explored. So what should be the threshold? A less stringent threshold will drift toward over-inclusivity, early investigation, and utilization of unproven treatments, whereas a higher threshold may hamper the discovery of actionable findings. And these thresholds, we should also acknowledge that they're all arbitrary, and a cumulative live birth rate of 98% following 5 haploid transfers challenges less stringent thresholds. And all these models, they assume that, if you use the haploid embryo transfer, then we assume that all haploid transfers have similar implantation rates, which is not the case. I would like to quote this elegant systematic review by Filippo Ubaldi's group, indicating that the embryo quality factors, the female age, BMI are still there, have statistical impact on the live birth rates. So having said this, there are several limitations for a personalized effort to define RIF. One of those is the number of those failed embryos to define RIF should not only be adjusted by female age and employed status, but also other factors affecting implantation. BMI, day 5 versus day 6 or 7, etc. And also these definitions assume that the oocytes, and thus embryos, produce one stimulation cycle are independent. Actually, this is not the case. And there is data supporting that there is not the case. In cycles, for instance, in cycles with low fertilization rate, and this is referred to as oocyte cohort effect, the cluster effect. In cycles with low fertilization, either with conventional IVF or ICSI, those normally fertilized eggs have lower implantation potential compared to those cycles with normal fertilization rates. And another example is that for ICSI, with abnormal fertilization, say triploidy, in that cycle, for those embryos who have normal fertilization, have lower implantation compared to those cycles without such abnormal fertilization, even though they have similar embryo quality. So this should be kept in mind. And obviously, such models should be externally validated. So very shortly diagnosis, the working group reassessment of life. Ideally, all factors that could have detrimental impact on an IVF cycle should be ruled out, should be diagnosed, and should be treated before embarking on an IVF cycle. So obviously lifestyle factors, endometrial thickness, there is recently available controversial data. It's a mild predictor of live birth. If there is any personal history or family history of thrombosis, well, you can be considering congenital or acquired thrombophilia. Karyotyping can be done. The integrity of the uterus should be assessed preferably by 3D ultrasonography. If the late follicular phase ultrasonography is fine, there is a trophy trial indicating that it doesn't help to do hysteroscopy in such cases. Endometrial function test and chronic endometrial, I'll be coming shortly. Assess the acute hyperthyroidism should be ruled out. And Alberto very nicely talked about the need for progesterone levels in fresh and frozen embryo transfers to optimize the results. So having all these, diagnostic tests, they should all be done before the first IVF treatment cycle. And might be parental karyotyping is the only test that might be considered in RIF cases. Well, the endometrial receptivity assay is very commonly performed in such cases worldwide. This is the big randomized multicenter trial following, single euploid embryo transfer. It doesn't improve the results. It might even be associated with worse results, as depicted by this Cozzolino study in both autologous cycle, egg donation cycle with or without PGT, and personalized embryo transfer policy might be associated with worse outcome. And this is a recent systematic review. Once again, it doesn't help in a subgroup of patients with implantation failure. But obviously, just this is one function of endometrium. This does not mean that other endometrial function tests in the future would not be helpful. What about chronic endometritis? I just put 3 reviews with contradictory results. And the main problem with chronic endometritis is the diagnosis. The diagnosis is hampered by, the lack of standardization of the plasma cells, immune-stained plasma cells, what should be the threshold. But in the future, with more DNA-based technology, the screening and treatment of such endometritis might find a place. So although other testings, in particular immune testings, they are not recommended to be performed in RUF cases. What about the management? Once again, they all apply even for the treatment of the first cycle. if you find any problem, any structural problem with the parental karyotyping, PGT, optimization of lifestyle factors. Nothing in particular regarding the RIF cases. And all other, immune therapy, intentional endometrial injury also has been very commonly performed worldwide. And despite the very recent patient IPD meta-analysis by Ben Moll, just favoring the performing, endometrial injury. All the, the other data refute the beneficial effect. And all the, the other tests, all the therapeutic interventions are not recommended. Obviously, supportive care should be not only be given to RIF cases, but also, I guess, should be given to all patients embarking on the first IVF cycle. And we should be shifting the paradigm from just one cycle to a multi-cycle approach. And it has been reported that the patients are ready to undergo multiple cycles. At least 1/2 of the couples are ready to undergo multiple cycles, and they should be informed in advance the need of such cycles, and to avoid unnecessary dropouts, and to avoid the use of funds to unnecessary diagnostic and therapeutic interventions. So to conclude with, in the absence of an obvious factor affecting implantation, the embryo is the main determinant of implantation success or failure. Euploidy is the most, but not the only determinant of an embryo's potential for live birth. A diagnosis of RIF can only be made when the transfer of certain number of embryos assumed to attain a predefined cumulative pregnancy rate has failed to result in a positive pregnancy test. And the number of those failed embryos to define RIF should be adjusted by female age, ploidy status, and ideally other factors affecting implantation. And given the stable and high live birth rates, up to 5 euploid blastocysts unexplained recurrent implantation may have a prevalence of less than 2%. And the thresholds to define RIF are arbitrary, and lower thresholds may result in premature implementation of ineffective diagnostic and therapeutic interventions. And following rule out obvious reasons for implantation failure, perhaps parental karyotyping is the only remaining assessment to be done in the case of unexplained failures. And we should be providing our patients supportive care, and proceeding with another embryo transfer can be the best next steps once a known etiology, obvious etiology for implantation failure is ruled out. Thank you.